Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next, I would like to introduce you all to today's guest speaker. Joining us today, we have Barbara Moscowitz. Barbara is the founder as well as dementia care and education specialist for the Dementia Caregiver Support Program. The program is part of the Dementia Care Collaborative within the Division of Palliative Care and Geriatric Medicine at Mass General. It was created to educate and support patients, caregivers, and healthcare providers. It offers opportunities for learning and connecting across the hospital and into the community at large. Barbara helps teach new ways of understanding dementia and how to best communicate and partner with those with dementia. She offers support and guidance for caregivers to feel empowered to foster their own well-being and resilience. She joins us today to give a presentation on understanding and living with dementia, so please join me in welcoming Barbara.
Thank you. Okay, thank you, Amy. And it's a pleasure always to be involved in any program that the Blum Center runs. We are so lucky at Mass General to have the Blum Center. So first slide, please. Thank you. And I'm going to navigate, next slide, please. I'm going to cover with our audience a big topic. And I hope to at least review with you some of the key features, and then enough to enable you to go forward with whatever research and activities that are important to you. One thing that's so important to know is that memory loss is not an inevitable part of aging. I think that's a misunderstanding in our society. It is true that memory lapses can be frustrating, but they're not always cause for concern. Physical changes due to age can cause brain glitches. Sometimes, in fact, difficulty hearing, difficulty seeing can impact the way we take in information and access it later on. But if we give ourselves time, the information eventually comes to mind. Other cognitive abilities stay intact when we are aging and well. The ability to do things we've never done before. We apply our history of skills and skill building to new activity. The wisdom and knowledge from life experience, or I prefer the perspective. When something is overwhelming, we have the ability to say, well, have I ever been through something like this before? Yeah, I have. I can do this. Common sense and the ability to form reasonable judgments. That's an important part of the gift of being older. And here's what's important, because it feels, I think, to many of us when we read the newspapers and listen to the news, that Alzheimer's is everywhere. And it is true that the risk of developing Alzheimer's or a related dementia increases with age, but it is not part of normal aging. Next slide, please. And so in some ways, it is, I guess, a paradox. The pleasure or the beauty of living longer also comes with the risk of developing a dementia. And I'd like to begin our conversation today with the question, what is dementia? I'm often asked, what's the difference between dementia and Alzheimer's? And I'd like to explain that dementia is an umbrella term. It is a medical condition that can include the following symptoms. The other thing I want to clarify, you see up in the title that dementia is a brain disease. And, you know, in neurology and geriatrics, which is where I work, it is very important that we name dementia as a brain disease. We talk about heart disease. We talk about kidney disease. We talk about cancer. And yet, because brain disease is expressed and manifested through behavior or language, it sometimes is hard for us to realize that it's all because there's illness in our brain. And that is part of what makes this a very complicated topic and issue, which I hope to offer some clarification on. So I'm going to read to you some of the signals about what might be dementia and what an individual might be experiencing. It's a condition that includes the following symptoms: memory loss that disrupts daily life. Now, note here, it disrupts daily life. I forget things all the time when I'm double tasking or multitasking or feeling stressed, but we all can recover that memory or work around. A memory loss that disrupts daily life is about not going to work or not picking up my child at school. Challenges completing familiar tasks. And that might be suddenly not being able to use the microwave or not being able to do taxes. Confusion with time or place. Now, remember, you might be thinking, oh yeah, that happens to me, that happens to me. Every one of these items happens to all of us in small doses. We're talking about a constellation of these symptoms that truly impact one's independence and ability to function as adults. Confusion with time or place, trouble with visual or spatial perception. That is sometimes a surprise to people who, when they hear if they have a dementia, shouldn't drive or need to be careful. New problems with words and speaking or writing. My mother, who has always been able to tell me everything that's on her mind, now struggles because she has Alzheimer's with word finding and sometimes even has difficulty understanding, misplacing things or losing the ability to retrace steps. Now, I'm sure that nobody on this video is listening who has never misplaced something, but we are able, if I misplace my keys, I can calm myself down and say, well, what was I doing when I came in from the car and then threw my keys down? I can retrace my steps. When an individual with dementia loses their wallet or loses their keys, they typically do not have the memory of what they were doing preceding the loss, nor are they able to conceptualize, well, if I was coming home from work, here's what I usually do. Decreased rapport judgment, which we'll talk about, withdrawal from work or social activities. Someone who is always happy at a social occasion might suddenly not want to go. Changes in mood or personality. So remember, these are some of the symptoms that might apply to an individual who has dementia when it's diagnosed. Next slide, please. Now, this is an important slide for a really profoundly important reason, because, as I said, when dementia, a form of dementia, is diagnosed, and it does reflect a brain disease, it is expressed through a change in personality or a change in my judgment or a change in my ability to do something. Now, because it's behavior or speech, how do you know if I'm not just being stubborn? I've always been stubborn. Or what if there's been a stressful experience and I'm just feeling kind of tense? Or if I say there's absolutely nothing wrong with me, you're imagining, maybe I'm in denial. And those are important issues that further complicate for you when you have a family member or a good friend trying to sort out what might be illness, which needs to be investigated, versus what is the behavior style of my relative. Some examples, and again, I want to acknowledge, and that's why I'm so proud to have the job I have, to validate for you that this is complicated, and we are here to help you sort out how to take one step at a time. Some examples of people who are struggling might be falling for financial scams. My father was someone, he was an accountant. He knew how to handle everything. And now we learned he just suddenly gave away $30,000. Was he just in a bad mood? Did he get confused? Going outside without a coat in cold weather, that's not just a one-time shot. But what if my father goes outside just about all the time, improperly dressed, unaware of declining abilities? Now, again, I'm not as good at my job as I used to be, or I can't manage my checkbook and I used to. Is that understandably normal? Is it time for me to retire? Do I just need new reading glasses? Or is there something in my brain that is making it hard for me to do these things? Refusing medications, doctor's appointments, help with hygiene. Next slide, please. I mentioned this early because I want, again, please, for you to know, we understand the doctors, the nurses, social workers, those of us who are honored to work with patients and with their family, that a dementia, if and when it's diagnosed, is very complicated for an abundance of reasons, and we're here to help you sort it out. Now, this is helpful to know. Dementia can have many causes, and nearly 10% of people with dementia-like symptoms have conditions that are potentially reversible, including but not limited to infection, a UTI. Now that's interesting because a lot of us go through adulthood getting a lot of UTIs, and we get antibiotics and we're okay. But for older adults with some frailty, and if there's a potential dementia or an infection, and even if there's not a dementia, but when one is of a certain age, infections can actually cause a confusional state. And that doesn't mean I have dementia. Vitamin deficiency. There are a lot of older adults who perhaps don't eat as fully and completely as they always have, and there are some vitamin deficiencies that can impact one's clarity and thinking. Depression. I think many of you know that clinical depression has a traumatic impact on one's function in life. And for many younger people, when medically diagnosed as having depression, it can affect concentration quite dramatically. In an older adult, and I'm speaking 80 years and plus, if one is clinically depressed, and I don't mean a little sad, but clinically depressed, it can cause what appears to be an acute confusional state, more than just not concentrating. Dehydration. And medication side effects, pain and delirium. I can't tell you how important it is for us to be aware of all the medications we take, as well as those of our relatives. And that includes whatever everybody has prescribed, and especially what individuals are buying on their own over the counter. The beauty of working with geriatric doctors is they are very focused on the medication side effects, especially the mixture of one with another, because that often can cause some confusion. dehydration in this incredibly hot weather. For a lot of reasons, we've all been told to hydrate well enough. Well, one of the reasons also it's important is, especially in an older adult who just doesn't drink enough during the day. And you know, you may not want to drink a lot because then you have to go to the bathroom. And if it's hard for me to walk up the stairs, you start, therefore withholding some of your fluid. But dehydration can impact one's clarity of thinking. Pain. It is difficult to manage pain and to live with pain. And for some people who might have some chronic pain from chronic disease or acute illness, pain can cause confusion. And delirium. I'll go into delirium in another slide. But here's the important point of this information, that if you are concerned about someone, yourself, or someone who's just not thinking as clearly as they used to, it's very important to have all possible causes of cognitive disorder, which means confusion, evaluated and treated before one diagnoses dementia. So next slide, please. So what that translates into is, if you are worried that a relative is suddenly just not as clear in their thinking or articulation as they used to be, rather than immediately worrying, oh, does my mother have Alzheimer's? The first stop is the medical doctor, all right, to rule out, are there infections? Are there vitamin deficiencies? Is there diabetes? Are there conditions which, if we make some corrections in, will improve one's thinking? That's always the first step, medical doctor. Some types of dementia, if one is diagnosed, you've heard of Alzheimer's disease, vascular disease, dementia. Vascular dementia comes from one having usually very high blood pressure, and you have very small, what's called TIAs, trans ischemic attacks. Lewy body dementia, frontotemporal disorders. There are many types of dementia. So dementia is the umbrella term that covers many changes in an adult's thinking and processing. And then there are types of dementia. Just like if one has cancer, it may be breast cancer, kidney cancer, pancreatic cancer. So there are many types of dementia. You might hear that someone has dementia of the Alzheimer's type. So diseases such as Alzheimer's that cause dementia, unfortunately, are irreversible brain diseases that progress over time, destroy brain cells, and are ultimately fatal. And currently, there is no cure available, however many treatments are being explored. Next slide, please. I think that you are aware in the newspaper now of a number of different medicines that are suddenly available, which for some people who have early stage Alzheimer's may slow the progression. That is a whole field of research. Because many of us often hear the word delirium, I just want to differentiate for you what delirium is as opposed to dementia. Many of us at any stage, you may know people who have had surgery and gone into the intensive care unit. They are not necessarily older or frail, and they're suddenly very confused. Or people who have had eye surgery and or other types of sensory depriving procedures. So a delirium is an acute confusional state, as opposed to dementia, if diagnosed, which is chronic. It's diagnosed and it progresses. One can improve from a delirium. It might be post-operation, post-infection. A delirium is something that might have an abrupt onset if you have visited family or friends in the hospital, and yesterday they were fine, but today they are very confused. That's not dementia. That is most likely a delirium caused by medication, procedure, and of course you bring that to the attention of the treaters. Someone who has a delirium might have impaired attention and focus, might have fluctuating cognitive status, and again, it's potentially reversible, as opposed to a dementia, which, as I said, is chronic, meaning once diagnosed, it is long-term. The decline, barring anything unforeseen, is gradual. It could be months and years. When I say anything unforeseen, is that though one may have the brain disease of Alzheimer's, one's body is continuing to live and age. So if I have Alzheimer's and also have a heart attack, then my Alzheimer's may be impacted differently. With dementia, some people are agitated, but often attention is preserved. And unfortunately, next slide, please, it's irreversible. So what I want you to know, some of you may have relatives who have dementia and they have had a hip replacement and gone someplace for rehab, and they're suddenly far more confused than they were 2 weeks ago at home. So that's a delirium superimposed on a dementia. And with good, solid rehab, PT and OT, and orientation, our goal is that the delirium part of the confusion will subside. It takes time, but it will subside. So now is the part that is really important, because for those of you who have friends, neighbors, or just are aware that if someone does have dementia or worries about having dementia, where do I start? What do I do? Where do I ask for help? I want to validate for you, so you know it's not you, that as magnificent as certainly Mass General Brigham is, and it's superb, we have some of the most magnificent care providers here. Our healthcare system, as we have known it and as it's been developed, is basically designed for us when we are acutely ill. I need an operation. I have fallen. I have a new diagnosis of cancer. That's acute care diagnosis. However, when we have a disease that's going to be with us for a long time, that's when it's unclear in our system where we get the treatment and how we navigate. I want to validate for you, if any of you struggle with that it is hard. And that's one of the things that I am proud to be here for, to help people navigate. So most caregiving challenges for people with dementia and chronic illness require long-term support in non-hospital, non-acute care settings. So there is a disconnect. You know, if one's relative has had a heart attack and you're working, you might take a 2-week leave of absence and you hope that by the time your 2 week is up, they're better. If one's relative has a dementia of the Alzheimer's type and is quite frail and not necessarily safe at home, a 2-week leave of absence helps you maybe organize things, but their illness doesn't go away. So that's why sometimes it feels like a square peg in a round hole. Our system is magnificent for giving immediate care. It's long-term care that people with dementia need. So the challenge of greater need for support for prolonged periods of time in an era of dispersed family networks and changing healthcare system post-pandemic. Next slide, please. So what I am saying, if you are feeling it's really hard to know where to call, I am, again, want you to know that my program, my colleagues and I, we're here to help you sometimes know where to make that first step. Now, this is a dense slide. I'm going to read it quickly, but what I want you to understand, if I may, very much so, there are reasons. There are sociological reasons, meaning our society, our culture has changed over the past decades. There are medical changes that impact the experience of having disease and even caregiving. My own grandmother was cared for in our home when I was a child. And I know that at that time, my mother was not working. And at that time, there wasn't much treatment available for her. So when she was able to be cared for at home 30 years ago, that life is different now. She perhaps would have chemotherapy, radiation. My mother would be working. You see, it's a different world. And it's not meant to excuse us. It's meant to give you a framework. Because what worries me is a lot of us say, well, my mother did it, my father did it, my sister did it, I should. We're here to help you figure out how you can manage now. It's a different world. So just some things to be aware of. And I'm going to read this pretty quickly. So we have medical advances and increased lifespans. People are living, as you well know, into their 80s, 90s, 100. I work with a wonderful woman who at 95, speaks of her daddy, who is 118. It's a little bit shocking, but not that much. We have improved management of illness. Acute care intervention now leads to long-term chronic care. If someone now has a serious heart attack, we have magnificent treatments that helps one recover and then have medication, exercise, and long-term follow-up. So we are living longer. Some of us are living longer with chronic illness that requires some care for us or care from others for us. And that's different from decades ago. As many of you may know, our hospital stays are shorter. It used to be that if one came in for a gallbladder operation, you may be in the hospital for a week. Now, some people come in for an uncomplicated gallbladder operation and you're out in a day. But that means something. What does that mean? That means if you're out in a day and you need to go home and you don't feel well, who takes care of you? And that's why there's this exciting change in medicine, but in terms of the care network, that's important to notice. Expedited discharge planning. Many of you now are aware that within no time, a care manager, a case manager may visit the room of someone and say, well, we could start looking at where to go to rehab. And that is a surprise. Geographic relocation of nuclear and extended families. 20, 30 years ago, many families settled in or longer in the same community. And yet part of our culture and our change is many families now have relatives all over the country. And that means that if one is ill at home, I might not have my 3 children living, on the next block. There's a change in our communities where we could traditionally rely upon for support our churches, our synagogues, and our neighbors. Some communities still have that, but not as naturally as historically. There's that demographic shift. We have older patients, therefore older caregivers. I work with a wonderful 85-year-old woman caring for her husband who's 91, but she at 85 has a good number of chronic illnesses. So in caring for her husband, she has her own health challenges. More of us have single parent homes, blended families. And then there's a concept which may be new to you called reverse migration. And that is many older adults who retired perhaps to Florida or a warmer climate. If they have survived and lived well to be in their 80s or 90s and need care, many people are coming back to the communities that they left to be closer to their family. So there's a name for it. Diminished availability of formal caregivers. That's a whole other story, but especially since the pandemic, if one is in the position to want to hire help from an agency to come in and care for my relative for 3-4 hours a day, it's available, but hard to find. There is a shortage of aides in our communities here. Long-term care for people with dementia is uncovered by Medicare. Now that's a whole other story, and it comes as a shock. What could be more profound and life-changing than if one has Alzheimer's, which means I am losing my grip on the world around me, and yet Medicare, which is the insurance most older adults have, as well as other acute care insurance, doesn't cover the long-term care that I need. It covers the diagnosis, the workup. It covers me if I'm in the hospital for pneumonia. But once I start needing care to manage eating, dressing, taking my medication, and surviving, health insurance doesn't cover that. And that's an issue in our society. And many of you have also heard of the sandwich generation, which is all part of our demographic shift. Next slide, please. And that's when we have middle-aged children who are caring for perhaps teenagers and parents. Here's a quote from someone I think is right on. Other than death of a loved one, few things are more disorienting than making the shift from being cared for by your parents to caring for them. This transition is made even more challenging because it usually comes as a surprise. And it's not just the biologically wired blind spot we have against our parents' vulnerability, it's the utter shock that when it happens, there's no place to turn for help. It's like trying to climb a rock face without any toeholds or crevices where you could grab on, and then scaling without a net. That speaks to being afraid. The problem with our aging system is that even though there's a lot of information out there, the situations most caregivers confront are so incredibly complex, unique, and specific. Like, why won't rehab accept my dad? Or that they can't find exactly what they need. Or they want the one right answer to a very complex question that doesn't have the right answers. And that, again, I want to validate, that is more and more the situation for even me. I've been a social worker at Mass General for over 30 years. And the more I explore and research our system, I respect that it's more and more complex. This is a wonderful website, daughterhood.org. I recommend. Next slide, please. So again, this is my way of telling you that's why I'm here, and my colleagues in the Dementia Caregiver Support Program are here, and many social workers and care managers are here, and it's hard. So I want to have a few slides of, if you want to say, how do I get started? I have a couple of priority points, and these are the needs of a person with dementia and their caregivers. Some clinicians prefer to call caregivers care partners, which I think is wonderful. So number one, when it is possible, you want an accurate diagnosis. And that comes from my telling you that if a relative is confused and is 85, it's not absolutely dementia. It may be a thyroid problem. It may be something else going on. So when possible, we don't assume. That means starting with your PCP, the internist, or if you have a geriatrician who is an internist with an expertise in geriatrics. At some point in time, a doctor might refer someone to a neurologist or to a geriatric consult. In our hospital, we have a wonderful geriatric medicine unit at that number, 617. And if you were to call them, they have access to 2 different kinds of consultations. In other words, my relative may already have a primary care doctor. I might speak to the primary care doctor who says, well, you know, we need a little bit more exploration about what's going on in your mother's confusion. Well, this unit does consultation. There are 2 different kinds, meaning one for an older adult who has a lot of what we call medical complexity, and there's a need to rule in or rule out what's going on medically before thinking about dementia. And there's another consult, which is for an individual who has had all of the medical complexity worked up, but there's still some confusion. And all you need to do is have your doctor, or you can call, your doctor can write the consult, or you can call and speak to someone about a geriatric consultation. So start with a diagnosis when possible. Here's something that I think has become more of a reality in the last 10 years. When you can, for you and for any relative whose life you're involved in, identify the clinical providers on one's team. Your doctor, any specialist, you have a cardiologist, you have a neurologist, a urologist, case manager, social worker. And I tell you that because if one has what we call a spell of illness, I come into the emergency room at Mass General. Well, a case manager is going to give me her card and meet me there to talk about perhaps making plans if I'm ready to go home. But then if I wind up being admitted to one of the units in the hospital, the case manager will introduce herself or himself there and give me a card and say, well, if you need a rehab stay, I'll help you. And then if I go home and have the visiting nurse or other people, a social worker may come to visit me and say, I'm here to help you set up support. So sometimes, and this is, perhaps the beauty of too many cards, it's really important. A lot of these magnificent people are there for us for a period of time. And it's helpful to know if you're only here for me when I'm in the emergency room, and I'm not going to keep your card. What I mean by all of this is there are a lot of people associated often with an older adult. It could be a case manager who's on your Medicare Advantage plan. And what is the most helpful thing for you to do, and then we'll go on, is identify, have a piece of paper with the name and telephone numbers and contact of the people who are involved in your person's care, and have an explanation of how they help the person and where. So for example, if the social worker and the visiting nurses can only help me for as long as the nurse is helping me, then I know that stops. This will serve you and save you a lot of time. And it may not be a question you used to need to ask. We used to have one case manager, maybe one social worker. Now we have multiple wonderful professionals, but a lot of times they overlap. Now, here's what's important, and this is an important reference. When we can, if you've been given a diagnosis of dementia for a relative, learning as much as you can about the disease is very helpful. What stage? What are the functional capacities? What are the emotional needs of my aunt who now has just been told she has Alzheimer's? Is she capable of driving? Is she incapable of doing her own finances? How do I know how to plan for her? So one thing that is available to everyone at no cost, even independent of the care we can offer you here at the General, is the Alzheimer's Association at this 24/7 helpline. All you need to do is call, and you can request a care consultation. Next slide. They have superbly trained master's degree clinicians. And all you need to do is say, my father was just diagnosed with early stage Lewy body dementia, and we are so confused. Can we have a care consultation? They will arrange by Zoom or in person a meeting for whoever wants to come. They'll give you some information to read about, as well as resources to contact. I highly recommend that. And some more issues. Communication. Now, this is complicated. If my husband is in denial, but we don't know if he's in denial about his memory because it's emotional, or does he not know what he doesn't know, which is part of the brain disease. How do I communicate with his doctor to whom he says, everything is fine, my wife is exaggerating? These are issues. We can't talk about it in this presentation, but if it makes you feel worried and concerned, because you feel your relative is telling the doctor everything is fine and you know otherwise, we often will help you strategize about how, with respect for the autonomy of the individual and their privacy, there is a way to provide information to one's doctor. We can't necessarily ask for information back, but providing information is possible. This is something that is overwhelming, but all of us need to do, and that's called advanced care planning. When someone has a brain disease, while he or she is still able to talk with you and their family about, here's who I want to handle my legal affairs if I can't. Here's who I want to handle my finances if I can't. Here is how I want to spend the later years of my life. If when that time comes, I can't tell you then. So this is hard and so profound. And social workers, doctors, nurses, we are all trained to help individuals with dementia and their family think through these issues. Community resources. Just want you to know, if you want to know where to start to look for services in Massachusetts, this is the website for the Executive Office of Elder Affairs, and they will help you identify in the community in which the individual lives. They will help you identify the elder care agencies to call. I also want to tell you that our own Partners Employee Assistance Program is spectacular, and it's a service available to all of us. If you don't know where to start, you give them a call, and they are magnificent clinicians. The Dementia Care Collaborative is the program I am proud to be part of. That's our website. If you look up, you'll see our site. You see the programs we have, the lectures we have, the seminars we have, and you can read all about us. Next slide, please. And now we're going to just spend the last 10 minutes, but this is a profoundly important issue. So what I hope that I've done thus far is let you know that it is not normal to have Alzheimer's or any form of dementia in old age. If there is in someone you love change in thinking and behavior that becomes a pattern, it's important to have a medical doctor intervene. And calling one's PCP is the step first, before you assume that is dementia. And then what I've also acknowledged for you is, if you think the system is confusing, I'm the professional who embraces it, and it is confusing. So if you think sometimes of a social worker as or a case manager or a nurse as an interpreter, we're here for that, because it is hard. Now I'd like to turn to the issue in the last 10 minutes of providing care or receiving care. And Rosalind Carter, the wife of President Carter, who is a magnificent woman and has devoted her post-president years to creating the Rosalind Carter Institute and devoted to caregiving, she says there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. Next slide. And isn't that all of us? Which is why our society needs to embrace the reality that modern medicine is helping us live longer, and that is a great gift. And while we are living longer, we may not be able to live as independently, either because of some thinking disorders or body frailty, as we want to. And therefore we need to think about, so how do we support people who need care when their families are working or live in other parts of the country? That is the cultural change we're involved in. Now that I'm going to give this list very quickly. Factors that impact the experience of giving and receiving care: cultural norms. Many of us come from traditions where there are absolutes about where relatives age and how they age. Family promises, legacy. I have a feeling that there are many people I know I was one. We have a family legacy. My mom cared for grandma, therefore I'll care for mom. Many of us have that in our DNA. Competing responsibilities. I have children, I work full time, and my mother needs me. That's a reality that I need to cope with. Now, my own health might not be good. If the caregiver for someone with dementia just had a heart attack, we need to address that. Relationship history. My parents might be needing care now, and yet I had a very complex growing up. And if growing up was hard, it may not be natural for me to step in and provide care. I'm naming these. There are no solutions. These are naming. I'm just letting you know life is not the way it is on television. Real life is textured, and real life is something we honor. There might be differences of opinion. Someone might say, oh, she only needs someone to drop off groceries. Someone else might say, I went to visit grandma the other day and her medicines were on the floor and she has heart medicines. We have to figure that out. Discomfort or comfort with hands-on care. It's not natural for a daughter to bathe her dad or a son to bathe his mom. We need to know that if those needs are ongoing. Long distance caregiving, which I talked about, and finances. Next slide, please. Financing what's called long-term care, as opposed to financing the stay at Mass General or financing a rehab stay at Spalding. Our insurance covers that, but it is difficult and expensive to finance all of the other kind of care, which can be life-saving. Getting meals, giving me my bath, helping me take my insulin, but that's not covered by insurance. Now, I just want to make a quick comment about care receiving. Many of you may be experiencing wanting to give care or help to your father, your mother, your sister, your brother, and they refuse. And it's very powerful to me when I realize that for someone who's ill, be it a brain disease or any other illness, needing care and no longer being able to care for oneself fully implies a loss of autonomy, independence, control, my identity. I may feel helpless. I could be afraid and angry. I might yell at you for bringing groceries, and that doesn't make sense. But it's not that I don't welcome the groceries. I might just be feeling so overwhelmed that I can't get them myself. Relocation. There are times when suddenly, because of illness, someone has to move out of their home. They lose their possessions and their relationships changed. I live down the block from my grandchildren, and now I need to move into assisted living and I'm losing my contacts. Loss of insight. Now, if I have dementia of the Alzheimer's type, I may not, because of my brain disease, know or believe that my driving isn't safe. I may not be able to understand because of my brain disease, and it's not denial that I can't handle my finances correctly. And that is a very complex issue, which may often lead to some defensiveness. And it's very important to have some clinical intervention there. By clinical intervention, I mean perhaps talking with one's doctor or neurologist about, is Barbara able to still drive, given what you've diagnosed as her brain disease? There are ways to have certain capacities evaluated. Hearing loss, decreased vision or mobility. If I have a slight memory disorder, but I also can't hear well, I can't see well, I am feeling defenseless and helpless and possibly just resigned, and it's hard. It's hard when I've lived my life vibrantly. Difficulty expressing thoughts and feelings, which sometimes occurs, especially when one has dementia, and the fear of the future. Or what's going to become of me? My husband just died. My children live in Colorado. What if I need help? So here's my main point, and then we're almost done. That at a most vulnerable time in an individual's life, which means in your life if you're in the family, when I am ill and I'm frail, I actually need to be flexible, make hard decisions, and often make big moves. Next slide, please. And that is very, very complicated. Now, the last 3 slides are just to name that with all of this practical work, there's a tremendous emotional side of caregiving and care receiving. And there are just last 3 slides. Many emotions surface when an individual is in need of care. For the person with dementia, for the caregiver, for family and friends. At any time, it's both normal and understandable to feel ambivalence, anger, anxiety, irritability, depression, and you see all the rest. In other words, at any time, it's understandable to feel tremendous emotion. Next slide, please. And among couples, sometimes for couples, they need to renegotiate their roles. The wife might have been the caregiver to the husband, and if she's sick, he's now learning how to be her caregiver. The caregiver may be frail. If there was a complex marital history, possibly domestic violence or addiction, that's an issue of complexity if suddenly their marriage is still in place, but one becomes ill. The spouse may lose a confidant or best friend. I spoke to a woman a few months ago who said to me, "Oh my gosh, I'm so sad. I have so many decisions to make. I just need my best friend, my husband, but he has Alzheimer's." So there's grief and there's great sadness. And there is also, next slide, please, changes in intimacy as a result of caregiving. Adult children. Now, adult children may lose the real or idealized parents or ones they never had when their parent becomes ill. There might be unresolved issues between siblings that emerge at the time of a parent need, and stress related to nuclear family responsibilities, professional life, personal, physical, emotional needs. Next slide, please, all surface. This is a way of saying our families have history, have legacy, have culture, have patterns, and at times of illness, a lot of it surfaces, and it could be very confusing. Finally, caregiving with siblings. As a family, carefully consider or reconsider all the caregiving responsibilities. Think about family roles when growing up and how they can or must change for caregiving. Siblings may have different ideas about what parents need, how to resolve. Try to separate parents' needs from my own needs, and yesterday's battles from today's decisions. And last slide, you'll have these slides so you could read more. These are some resources to be helpful to you. The top one is the program that I am honored to work for. The state, the Executive Office of Elder Affairs, Boston Elder Info is a telephone number you can call, the Alzheimer's Association. And if you're interested in a marvelous website, the Family Caregiver Alliance, and I'm finished, you can pull the slides down. If you log on to them, they have health information, they have resource information, they have information about emotions. I recommend it highly. Thank you very much. And Amy, I'm happy if there are any questions to take.
Thank you so much. We are now at the end of the session. If you have any questions for Barbara, feel free to enter them in the chat. We have an attendee whose mother is in the stage where she knows what she knows that she's losing her memory, but can still take care of the activities of daily living on her own. The awareness of her memory loss is crushing to her pride, totally, completely understandable. She asks me if there is anything she can do to address this. Are there exercises she can do, supplements she can take, or other ways to preserve or at least slow the decline of her cognitive abilities? She doesn't want to have any medical intervention, such as MRIs, etc., because she thinks she knows the answer and she knows there's nothing that can be done.
Well, thank you for your very, very wise question, as well as your mother's. I'm going to tell you one thing. The answer is, if you look on our website and others, yes, there are things to do. I will tell you that the prescription neurologists give to people with memory deficit when they're diagnosed is they often say what's good for your heart is good for your brain. It's very important to eat well with full nutrients, to exercise, getting out and exercising, or if you can't get out, yoga or concentration, and social stimulation and engagement, talking, having some activity, enjoying music. So the answer is, and this is in fact researched and written about, eating well, also sleeping well, exercising, and being involved in life. Those are the ways that people can feel valuable, feel best, and it does make a difference. Thank you, Amy.
Thank you. What are some ways caregivers can take care of themselves to prevent burnout?
Oh, welcome to the universe. Actually, very important. The most important thing, frankly, is to recognize that caregivers deserve and must care for themselves. Because remember, I was talking a lot about when one has dementia or a chronic disease, it's not over in 2 weeks. It could be years of managing care. So there are many ways. By the way, in our program, in fact, even tonight, we're having a program. We have a health and resiliency program. We have programs on Tai Chi, on meditation. But the point is, here's the point. The mistake is, we all think that self-care means I've got to be able to have a lot of money and go to a spa in the Berkshires. Self-care is, first of all, what you've just asked, recognizing you deserve to care for yourself, finding any amount of time, even if it's a half hour, that is completely and utterly yours. If you're caring for a relative who is in danger of walking out of the house, then assign someone to watch that relative so that you can do whatever you want to do for that half hour. So be it ice cream, a talk on the phone with a friend, anything. Our time is limited, so please know the key is whatever works for you and make it happen. And a lot of times family members don't ask you if they can help you. So one big thing is finding a way to let people know you need their help. Thank you.
Thank you. We have one final question. What are some tips on how caregivers can support a loved one if they don't live with them?
Fabulous. One important thing is with your loved one's permission. It's really helpful if they share with you the telephone numbers of their close friends and the people in their life. So if you were to call and there's no answer on a Sunday morning, you're not stunned and unaware. So see if you can come up with a plan with that loved one. Can you share with me people I can call if I'm worried, or what I can do? And then arrange, we all learned to use Zoom and FaceTime during the pandemic. One of the things that's very helpful for all of us, especially for people who have some frailty, is to be able to expect a call, a visit. And, so if you're able to make a commitment to, I will call you every Wednesday and Friday, and setting up a schedule of calls, contact, having people know that someone knows I'm here is a really life-saving gesture. Thanks.
Thank you. So we are at time. Before we end today's session, Barbara, do you have any final thoughts you'd like to share with the audience?
Other than, Amy, thank you for giving me this honor. I really just want to share with the audience that my colleagues and I and the wonderful clinicians here, we want you to know that we respect this is hard. And you wouldn't trust me if I said, oh, it's as easy. It's not. But we're here to support you and to help you navigate this difficult journey. And thanks to Amy and the Blum Center who could provide information. There are lots of people in this organization who care about you. So thank you.
Thank you. And for everyone who took the time to join us, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. If you'd like to view the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you.